Good evening to all attendees, and welcome to a scientific symposium tonight. Let me introduce myself. I am Apisha Supatamvit, Assistant Professor from the Department of Anesthesiology, Faculty of Medicine, Sirirat Hospital, Mahidol University, Thailand. And it is my privilege to be your moderator and the speaker tonight. We are gathering here to join the scientific conference under the topic of the from basic to magic anesthesia, sharing experience from our APAC networks. It was organized by an MSD Thailand, and thank you very much for that. Personally, I think the topic is very interesting because from all our daily routine work, the basic ones, it can become the magic moments and all the transformative experiences to our patients. So let me check that. We're gonna have 3 speakers from the APAC region joining us tonight. And we're gonna share our experience and also our knowledge and our updates with you guys, and hope that we can make it different and improve the patient safety and everything after this conference. Before we kick off the scientific session, please note that this meeting will be recorded and will be ready, available to replay in 7 days. If you have any question, please feel free to submit them on the question log on the platform. But for all of us here, you can just raise your hand and ask for the microphone after the concluded of each section. So let's start our scientific session today. From the basic general anesthesia, I believe, like since we are trained in our anesthesia training, we know that it consists of the 3 major parts. The first one is the anesthesia. We use some like intravenous induction or the inhalation just to make the patient fall asleep, cannot remember anything. The second one is the analgesia. We want the patient like the pain-free after the operation. We use multimodal, and it was very popular and on the like daily basis. Last but not least, the akinesia. The patient should be lie still at the operating table, don't move, especially at the critical period. We mostly use the neuromuscular blocking agents or neuromuscular blocking drugs just to provide the akinesia for the patient and also to help the surgeon to do that job. So the neuromuscular blocking drugs is very popular and was one of the most used by the anesthesia personnel, by the critical care physician, and also by the ER physician, just to have the purpose for facilitate the airway management, to improve the surgical conditions, to ensure the immobility during critical period, as I said before, like especially for the eye surgery or the neurosurgery. And also was used by critical care or intensivists just to support the protective ventilatory settings in the critically ill patient. So if we use it prudently and wisely, it can reduce the postoperative pulmonary complications like pulmonary aspiration, upper airway obstruction, or the reintubation rate, atelectasis, and also reduce the hospital stay and also the ICU stay. So it also has the perspective of the cost effectiveness. And finally, it can improve the patients and also their relatives' satisfaction as well. So it comes to the agenda of the talk, the scientific talk today. We divided into 3 parts. It's very interesting and also connected. The first one is the neuromuscular blockade management, the guidelines and the update. The second one is how we implemented the neuromuscular blocking duct into the enhanced recovery after surgery. Is the perspective from the Taiwan speaker. And the last but not least is my privilege to deliver the talk about the reversal option for the better patient's outcome. So let's start with our first speaker, Dr. Joy Luat In Jeong. Please forgive me if I not pronounce it right. So she's a speaker from our neighbor, APAC neighbor from Philippines. She graduated medical degree from University of Santo Tomas College of Medicine and Surgery, Manila, Philippines, and also the anesthesia training from St. Luke's Medical Center. And she's now the program director of the residency training and the head of the Department of Anesthesiology at St. Luke's Medical Center. She also the president of the Philippine Society of Pediatric Anesthesia and the member board of the accreditors of anesthesiology. So, and she's gonna deliver a talk to us in the topic of updates of the neuromuscular blockade management and monitoring. Dr. Joy, please.
Hi everyone. So I'd like to thank MSD Thailand for inviting me to speak here in Bangkok, and I'd like to thank all of you here present and the ones who are currently logged online from Vietnam and the Philippines for taking time to attend this on what you would typically spend with your family. So my talk, as I was introduced, is actually on neuromuscular blockade management and monitoring. And I will touch on the incidence of residual neuromuscular blockade, the repercussions of residual blockade, and then give you the updates on the new guidelines on neuromuscular blockade management and monitoring, and what are the new gadgets out there for neuromuscular monitoring. So my disclosure is I am a member of the anesthesiology faculty of MSD Philippines, but I'd like to tell you that this talk and presentation was personally prepared by me based on my research and readings and my personal experience. So I'd like to start by stating this study by Beecher and Todd in 1954, when this data were collected by 10 teams from 10 different hospitals over a 5-year period of time in the United States. And in this study, all causes of death were determined by teams at each hospital. The data were collected in very large number of patients, in fact, in almost 600,000 patients. And what did they find? There were two interesting findings related to neuromuscular management. First was the fact that mortality rates when paralyzing agents were used were 6 times higher than when they were not used. And secondly, they also found that 63% of the deaths involving neuromuscular blocking agents were caused by respiratory failure. Just a show of hands from the audience that are present, who among you do neuromuscular monitoring perioperatively, routinely? So I see people shaking their hands, no one's raising their hand at all. How about routinely reversing your patients from paralysis? Anyone? Routinely reversing but not monitoring. That's nice. So I see some. So no judgment here. So I just want to know what is being practiced in Thailand in comparison with my country and other countries as well. So this next slide actually is a study by a very popular author, Debane, in 2003. And can I take this out? I'm sorry, because I cannot use the pointer because of the presentation. Okay, so you can see the x-axis is time, the y-axis is train of 4 ratio, and the lower horizontal line is a train of 4 ratio of 0.7, and the higher horizontal line is the train of 4 ratio of 0.9. So in this study, all these subjects, each triangle or each shape, was actually administered a single dose of paralyzing agent, only an intubating dose, no top-up doses. And then they took the train of 4 ratio at the end of the procedure. So the reason why I'm emphasizing the difference between the 0.7 and 0.9 is because in 1979, Professor V.B. Mogensen pegged at 0.7 train of 4 ratio, patients were already safe to extubate because at this level, the inspiratory force and the vital capacity were already deemed to be back to normal. However, later studies in recent years have shown that between 0.7 to 0.9, there is still upper airway obstruction, which can lead to aspiration. There's weakness of upper airway muscles. There's also an effect on hypoxic ventilatory response. So, if you are one of the practitioners who use, for example, atracurium, just one single intubating dose, you do not monitor and you do not reverse. If you look here, 350 minutes, so to 400, that's about 6 hours. There is still this one patient and all these patients who are still all below 0.7. So meaning, even for rocuronium and vecuronium, there's such a patient. So they may be outliers, but they're probably those patients who you leave in the recovery room that may have aspiration or residual paralysis and post-operative pulmonary complications, and you never reverse them. So we have a saying that what we don't know won't harm us, right? So this is probably the patients that we do not reverse and we do not monitor. So we really don't know what happens to them. So we're just lucky if no one calls us back to the hospital. And this next slide is the RECITE study. It's a Canadian study, and which was published in 2015. And in this study, just to put it simply, everything that is not green is not safe to reverse, because the ones in green, that's train of 4 ratio of 0.9, is the gold standard for extubation. So everything that's not green is not safe to reverse. So as a summary, about 56.5% of patients were below 0.9 and extubated and in the recovery room after surgery. And when this study was replicated in the United States a few years after, so there's such a thing as the RECITE US trial, the average incidence of residual block became as high as 64% from the 56% in the Canadian study. Okay, so for those who, again, do not reverse and do not monitor, and most likely we rely on clinical signs and symptoms to deem the patient safe to extubate and safe to wake up. There's this article published in 1997 where maybe some of you would try to elicit a head lift from your patient, like say, can you raise your head up from the pillow? But a true head lift should be 180 degrees, lifting from the pillow, and count 5. 1001, 1002, 1003, 1004, 1005. If the patient can do that, that's a true head lift. However, even if the patient can perform that, that is only equal to 0.6 in train of 4 ratio. Again, far from 0.9. How about the tongue depressor test? Or if your patient is biting on the oral airway, or what we call the tongue depressor test, even if the patient is clenching his teeth and able to bite against that oral airway, that is still below 0.9, because that's only 0.8% in your 0.8 in your train of 4 ratio. And in this slide on the lower right-hand corner, in this table in the lower right-hand corner shows the different equivalents of your different clinical tests in terms of occupancy of your receptors. So if you think that the tidal volume has returned to 5 mils per kilogram, but the normal tidal volume, as we all know, is 6 to 8, even then, the receptors are still 80% occupied and down the line. All right. So I did tell you that I will discuss with you the new guidelines. But before that, what are the effects of residual block? So if you do not reverse, you do not monitor, and there is residual block that is not documented, then this study, which is with the acronym of POPULAR, is the post-anesthesia pulmonary complications after use of muscle relaxants, is a multi-center prospective observational study. And in this study, they found that the use of paralyzing agents is associated with an increased risk of post-operative pulmonary complications, and the use of reversal agents or neuromuscular monitoring actually could not decrease this risk. So in 17,000 of the patients receiving paralyzing agents, in about a little less than two-thirds of those patients, monitoring was not applied, and the extubation of their tracheas was based solely on clinical criteria. So approximately a third of the patients who received objective monitoring, that's acceleromyography, EMG or electromyography, were extubated with a train of 4 ratio that was less than 0.9. So what does that mean? It only means that when inadequately managed, paralyzing agents or neuromuscular blocking agents could lead to adverse events such as postoperative pulmonary complications. So before I discuss with you the very recent guidelines, I just want to show you the timeline of all the different international anesthesiology societies who have been dedicating their time towards the patient safety about neuromuscular blockade management and monitoring. And most of these societies have actually recommended the use of intraoperative quantitative, not qualitative monitoring. So I will start with a recent guideline published by the American Society of Anesthesiologists, or ASA, for monitoring and antagonism of neuromuscular blockade. So they have a specific task force for this. And it can be summarized in 8 statements or 8 recommendations. And the first 6 are actually strong recommendations in terms of grade. And in terms of evidence, it's moderate grade in evidence. So the first statement is, when neuromuscular blocking drugs are administered, we, or the ASA, recommends against clinical assessment alone. So not because the patient can stick out her tongue, the patient can lift her head. That's not enough to say that it's safe to extubate. Why? Because those assessments are insensitive. Second is, they recommend quantitative monitoring. Again, that's AMG, EMG, mechanomyography, kinemyography over qualitative assessment to avoid residual block. Third, when using quantitative monitoring, they recommend confirming a train of 4 ratio of equal or greater than 0.9 before extubation, or 90% before extubation. So those are the first 3 statements. Again, that there's with strong recommendation, moderate grade evidence. The fourth recommendation is they recommend using the adductor pollicis muscle as innervated by the ulnar nerve, or the that causes flexion of our thumb, for neuromuscular monitoring. They strongly recommend against using the eye muscles. That's the orbicularis oculi or the corrugator supercilii for neuromuscular monitoring. Why? Because these muscles actually are very good for checking if you are ready to intubate, because they approximate the airway muscles, but they are not very good for total return of paralysis of all the other muscles or nerves innervated by the other nerves in our body. And the sixth recommendation with a strong and grade and a moderate grade evidence is that they recommend Sugamadex over neostigmine at different levels of block, whether it's deep, moderate, and shallow depths of blockade. That's if you are using rocuronium or vecuronium, because Sugamadex is specific for aminosteroids. Just so we are on the same page on what we're talking about, if we're talking about deep, moderate, shallow, or minimal block, this is the accepted definition. Okay? So if you say deep block, that means the post-tetanic count is greater than or equal to 1, train of 4 count is equal to 0, and again, at the bottom of the slide is acceptable recoveries greater than or equal to 0.9. Then you might ask, what are the 2 remaining recommendations of the ASA? And these last 2 recommendations have been labeled as conditional and with low to very low grade evidence. So the 7th recommendation is that they suggest neostigmine as a reasonable alternative to Sugamadex at minimal depth. So they do not recommend it for profound, for moderate, and for complete, profound, and moderate depths of blockade. Only for minimal and shallower, okay? To avoid residual block when using atracurium or cis-atracurium, which are benzyl isoquinoliniums, when those are administered and qualitative assessment is used, they suggest using neostigmine at minimal neuromuscular blockade of depth. If the depth of blockade is more intense or deeper, they do not advocate using neostigmine. In the absence of quantitative monitoring, once you give neostigmine, they advise waiting at least 10 minutes before extubation. If you are able to achieve train-of-4 ratio of 0.9 and above earlier than 10 minutes, that's the only time you may extubate, but never earlier than that. So okay, so that was the American ASA guidelines, and now I will give to you the European Society of Anesthesiology and Intensive Care, or ESAIC, publication on perioperative management of neuromuscular blockade. So this team was led by Professor Fuchs Buder, who is an advocate of neuromuscular blockade management and monitoring. And they started with 3 clinical questions. So the first is the use of paralyzing agents necessary to facilitate tracheal intubation in adults? Number 2, does the intensity of block influence a patient's outcome in abdominal surgery, specifically laparoscopy or laparotomy? And lastly, what are the strategies for the diagnosis and treatment of residual block? So they actually gathered about 24,000 trials and ended up doing a full text review of just 88 trials. And the interventions were the use of different paralyzing agents, from succinylcholine, a depolarizing agent, all the non-depolarizing agents, and then comparing quantitative with qualitative monitoring, and then comparing reversal with Sugamadex as opposed to neostigmine. And just as a review of how they graded recommendations and the benefits to patients, this is the tabulation. So 1s are strong, 2s are weak recommendations. And I took it upon myself to again summarize the recommendations by the European Society. So muscle relaxants in tracheal intubation and rapid sequence induction intubation, or RSII. So the Europeans recommend using a muscle relaxant to facilitate tracheal intubation. So if there are those who still do not routinely paralyze to intubate, this is for you. They recommend you paralyzing the patient to reduce airway injury following endotracheal intubation. For rapid sequence induction and intubation, use a fast-acting muscle relaxant. So that is either a depolarizing agent using succinylcholine, that's 1 milligram per kilogram, or rocuronium at a higher dose, which is 0.9 to 1.2, as opposed to its routine dose of 0.6 milligrams per kilogram. The third recommendation is to deepen neuromuscular blockade if surgical conditions need to be improved, specifically in laparotomy and laparoscopy. And this comes out very repeatedly, the use of the ulnar nerve and quantitative monitoring at the adductor pollicis muscle or the thumb to exclude residual block. Also, they recommend using Sogamadex. Again, this came up as compared to the American guidelines to antagonize all levels of block, deep, moderate, and shallow neuromuscular block if you're using rocuronium and vecuronium. And but if you are banking on spontaneous recovery before starting neostigmine, they advise giving neostigmine only if you have already achieved at least 0.2. So if the patient has profound block, complete block, there is no place for neostigmine, as opposed to Sugamadex, which can be administered at any point in time. And the last one is, as you can see, grade 2C at the bottom, which means that it is a very weak recommendation and also weak evidence. There's insufficient evidence to recommend deep neuromuscular blockade in general to reduce post-operative pain or decrease the incidence of perioperative complications. So I will just go and compare the two guidelines for you to be able to visualize it better. Again, the Europeans advocate facilitate tracheal intubation, to use muscle relaxants to reduce airway injuries, use a fast-acting agent for RSII, that's succinylcholine, and higher doses of rocuronium, deepen block if necessary for laparoscopy and laparotomies or any other surgeries that require immobilization and more paralysis. And how do they compare? In terms of clinical assessment, they both do not agree on clinical assessment alone. They both do not agree on qualitative assessment alone, but they very much advocate quantitative monitoring, that's AMG and EMG, and do not extubate until you reach a train of 4 ratio of 0.9 or above. And even if you are just using a depolarizing agent or succinylcholine, which is known to be very short-acting, they still advocate neuromuscular monitoring. What muscle to use or what nerve to use when monitoring? Repeatedly, this comes out, adductor pollicis muscle at the ulnar nerve, and they do not advocate the eye muscles. So they are in unison in terms of when to administer Sugamadex. In any level of block, 0.4 and below, it may be given already, as opposed to neostigmine, wherein you need to reach a ratio of 0.2 to 0.4 before you can give it, and allow 10 to 15 minutes before you extubate or wait for 0.9. So this is just to show you the phases of neuromuscular block. So I'm hoping to influence you to use monitoring in your cases. And this is just to show you that you may monitor throughout your case, not just at the end, not just to find out if you're okay to extubate. Because in the beginning, you can use it after you've sedated the patient, given your inducing agent, check for train of 4 count, wait for it to go to 0, then that already tells you that you're good to intubate and the patient will not react. And then you intubate, and then you proceed to the surgery. Obviously, you've just given the drug. After giving the drug, the depth of blockade is still very dense and profound. And as the procedure goes on, and if you do not give succeeding doses of paralyzing agent, eventually the block will return from paralysis. So you can see train of 4 count becomes 1, 2, and 3. Most surgeries, or even open abdominal surgeries, only require a train of 4 count of 2 or 3. They do not need a post-tetanic count of 0. Maybe that's only warranted for what Professor Apichat said earlier, maybe for neurosurgery, retinal surgeries of the eye. And so after reaching moderate block, again, as the procedure goes on, that will become shallow, minimal in terms of blockade. And then if you need to extubate, you base the dose of your reversal agent on your train of 4 ratio, which is why it's important to monitor, because dosing, even of neostigmine, is based, whether it's neostigmine or Sugamadex, should be based on your train of 4 ratio. And so what do I advise for you to do in practice? This is a clinical practice strategy. And this is from guidelines again. Pre-induction, discuss with your surgeon what does he need in terms of relaxation, in terms of paralysis. Are you able to monitor based on the patient's position? I don't know how you do certain procedures here, but nowadays, lots of surgeons like their arms tucked, the patient's arms tucked, because it gives them more space to move around. But then when that happens, you're not able to monitor accurately because the thumb is immobilized. And then when you're preparing your monitor, make sure that the skin is clean and dry, and remember that the black electrode goes distally. That's a negative electrode. Remember to calibrate always, because that helps you confirm monitor function. It tells you if you've placed the electrodes correctly, and it also tells you timing and dosing. All right. In terms of maintenance, you may say, if the arm is tucked, what do I do? There's really no excuse not to monitor. If the arm is tucked, you can monitor in other areas of the body. So you can monitor the posterior tibial nerve, okay, which is behind the medial malleolus. You can also use the face muscles, the corrugator supercilii or the orbicularis oculi, but then return to the ulnar nerve, if you want to check if the patient is safe for extubation and safe to be awakened. So again, why do we need to calibrate? Because if you set the gain of the gadget too low, you may underestimate the response. If you set it too high, you may overestimate, and even artifacts may be registered as a response. And when you read articles nowadays on neuromuscular blocking drugs, you will repeatedly see normalization. And what is that? This is usually discussed in acceleromyography, or AMG, wherein the baseline more often than not overshoots the value of 1. So when you do calibration and the start and you get a value of more than 1, then your baseline is not 1, if it's 1.1. So in this example, if the baseline is 1.1, all your other train of 4 ratios afterwards should be divided by 1.1. Then eventually, you will get your train of 4 ratio. Okay? So in this case, the baseline was 1.1. So even if the monitor already showed 0.9, your train of 4 ratio is actually 0.82. So it's still not 0.9. All right? So this is just a tabulation of all the other monitoring devices that are available even for clinical research. And the next few are what is available commercially. Okay, so you might want to request your respective hospitals to request for this. This is Twitch View, that's EMG. This is Tetragraph, that's EMG again. StimPod can do both AMG and EMG. And this is hot off the press. This particular article compares all those gadgets, the 3 gadgets previously, with AMG gadgets, which is the TOF scan, the Philips AMG. And what did they find out? The AMGs actually, again, as I said earlier, they overestimate the baseline. So you need to normalize, okay? And there's also a wide variability. As compared to EMG, which is more accurate and precise. So they came up with the conclusion that EMG is more accurate and precise as opposed to AMG. Normalization reduces the overestimation, but it does not reduce the wide variability. So I'm in my last 2 slides. And what do we do during maintenance? Again, as I said, I advocate monitoring throughout the procedure. Why? Maybe some of you would top up, every 30 minutes? If you're doing I don't know, maybe, if you're doing an XLAP, topping up every 30 minutes, you may not have to top up every 30 minutes. If you're monitoring and your TOF says 1, you do not have to give the drug, actually, only if you monitor. But since you're scared of the patient moving, the surgeon getting mad, you give it every 30 minutes. But you may not have to, okay? So it can help you with dosing, all right? And then moderate block, as I said, is sufficient for most surgical cases. And then do we actually need deep relaxation for laparoscopies? And make sure that at the end you plan for reversal and recovery. It should take place based on the surgery, the depth of the block, and the availability of reversal agent. As a parting note, again, a chain of 4 ratio of equal or greater to 0.9 must be achieved before waking your patient up and before extubation, either by allowing pharmacologic spontaneous recovery or drug reversal with specific antagonists. What we have now in the market now is either neostigmine or sugamadex or other drugs in the family of neostigmine for reversal of residual neuromuscular blockade when indicated. So I think that's my last slide. I think I went over time by about a few minutes, and I will entertain questions whenever there is free time. Thank you.
Thank you very much, Dr. Joy, for the very informative talk, and you summarized the insightfulness of the how to use neuromuscular blocking agents, and also how to monitor to emphasize the importance of the monitoring of the neuromuscular effect. So We found no question from the audience virtually. Do you have any question from the audience on the floor? Please just feel free to raise your hand and ask for the microphone. While waiting, I have one that was very touched from I summarized from your talk that we all know the importance of the neuromuscular monitoring, but if you want to use it, you have to make sure that you use it right. Right? I very like very much from your talk. So my question is, do you have any suggestion or any studies that confirm the cost effectiveness of the neuromuscular blocking monitoring? Because you know that we have like many gadgets, or it was extra from the usual daily routine work of ours. Actually, as in Thailand, that you have seen that no one monitoring it routinely. What do you suggest or?
Off the top of my mind, I cannot state a particular study for now, but in practice, like I said earlier, if you are the practitioner who typically tops up or gives succeeding doses based on time or just based on the surgeon saying it's not relaxed, or because I'm going to give another dose because I'm going to leave the case, I'm going to the bathroom, take coffee, and leave it with a trainee. You may not have to do that if when you leave the case or you take a break or whatever, you're not yet due to top up. So what I'm trying to say is you may not have to give that much paralyzing agent actually. So in terms of cost, that's actually less. And then in the end too, you may not even have to reverse if you monitor, because if at the end you monitored, if you monitored throughout and at the end time has lapsed and you've already reached a train of a ratio of 0.9, you actually do not have to reverse. So in terms of cost and safety for the patient, you end up giving less drugs which may not be indicated.
Yeah, thank you very much. Anyone have any question?
Hello. Thank you for a very informative talk. My question is about the pediatric patients. Did all of these recommendations can be applied to the pediatric patients and the adult patients, and the TF ratio like 0.9 can be used in the pediatric patients as well?
Actually, these if and when you get a chance to review the articles in full, they are not yet applicable for pediatric patients. They still recommend doing more review of trials for the particular pediatric patient. But you did ask me earlier if I use it in my practice, and I have. But I just like to emphasize that using it in younger patients, it's an off-label use. I think the cutoff, if I'm not mistaken, is 4 years old. But experience-wise, I've used it in 2 years old, and I use a 4 milligram per kilogram dose. What I would like to add to my answer earlier, also in terms of cost effectiveness, is also using one reversal agent over the other. If you're using, for instance, Sugamadex, and you're able to reverse at any stage of the procedure, you get to finish surgery earlier, waking up the patient sooner, and taking a next case sooner. So for the hospital administration, that leads to a faster turnover time rather than you waiting for the patient to breathe because you did not reverse and you did not monitor. You need to wait for the patient to wake up. So in terms of cost, that maybe, I don't know, mathematically should balance out at some point.
Yeah, that one very. When I doing the review about the cost effectiveness, it's also happened in the States. Yeah, about the more case that you can do after one reversal agent. All right. Does anyone have any other question? All right. So we're gonna move to our next section. Please give a warm welcome to Dr. Joy. Thank you very much. All right. So our next speaker is our friends from Taiwan, which is our APAC networks. He is Dr. Guo Shulin. He is going to join us virtually from our program. He educated medical degree from the National Taiwan University and the Institute of the Bioinformatics and System Biology at the National Taiwan University as well. He is now the anesthesiologist and the key person of the Enhanced Recovery After Surgery program at the Cathay General Hospital, Taiwan. And he is the president of the Taiwan ERA Society. I think it is our fortunate to have him with us today and how he implemented the neuromuscular blocking drugs or reversal into the ERAS program. All right, so please give a big hand to Dr. Guo Shulin.
Yeah, thank you, everyone. And first, thanks Professor Abichat to introduce myself. And I think today I will give some Taiwan experience in ERAS. And maybe someone thinks that with any relationship with the squamous, I think that is a long story. And I will give some talk. I to introduce this relationship with the squamous. The first comments as we watch the three physician and with the different periods, like urologist contain the urine and the surgeon contain blood, and our anesthesiologist contain coffee. That's maybe feel some funny, but every time I look at this comment, I have some different thoughts. WHO to give some data about advanced event, because the unsafe care will lead to the patient days and disability. Advanced events may be ranking in the tens. And the other, the patient receive the hospital care and they will get harm due to the advanced event. The ratio may be about the 10%. Fortunately, that's the harm the advanced event. Maybe we can do something to prevent this event to hurt our patient. But the cost will increase the 15% to the total hospital activity and expenditure. So that is a very serious fact to us, because if we not really to take care patient professionally, and the patient will get harm, and that will hurt our professionalism. As we know, the surgical care is very important. In hospital, the most of the income and the bed occupied may be due to the operation. So almost half the advanced event may be related to the surgical care, like the patient fall and some abnormal medication error and the tubing event. That's all related to the surgical care. Almost half of this case will be preventable. So that means if we can do something and we can guarantee the patient safety in these surgical patients. But we need to know another issue is about complications, because maybe the operation is successful, but the patient will suffer from the post-operative complication. This complication will increase the cost above the 1.5-fold. So for the hospital, or for the healthcare provider, or even for the patient or their family. That is all the very big impact. So for the hospital, if we have the more and more the complication will decrease the bed turnover rate about 75%. So that's all tell us if we have the power to try to prevent some events, maybe the surgical care, we need to do that. In Taiwan, before we implement the ERAS, the anesthesiologist and the surgeon, the only thing to handle this the complication, not really a consensus, because we don't know the risk and to do the risk analysis due to the time occupied. And we don't have anyone serious to do the systemic risk evaluation or ranking. Even though we do the very passive the risk treatment, maybe that something happened and we just do to cure that. And the last, we will have the endless the reservation for post-operative ICU. So the ICU always occupied and occupied for the next day operation. So such as the quality variation of the operative care that will have the big impact for the patient or in the hospital, the running. So why will lead to this the difficult situation? I think the communication is key, because the surgeon and the anesthesiologist are always the team, but the team is your team. Even we will the same shot, that doesn't make a team, because we don't have the effective the communication, and we don't have the consensus, and don't have the same goal for the take care of the patient, and we don't have the really cooperation. Most of the situation we just and the duty, and we don't know even the other responsibility and the other physician the thought the how to take care of the patient. So the schematics the maybe is a good the starter, yeah, because just we will talk about a lot about the schematics, yeah, because schematics will benefit in surgeon and the anesthesiologist. So like this the strong study that we can show the patient receive the schematic treatment and they will decrease the pulmonary complication about also ratio decrease the 1.5. So that is a very strong evidence to convince the both side in surgical side and anesthesiologist side. So we in the ERAS protocol, like the CRS, the surgery, and in the standard anesthesia protocol, that is say every patient will receive the major colorectal surgery need to use the monitoring for the neuromuscular bracket, and we need to complete reverse. So the evidence is high and the recommendation grade is strong. So to come at this, we have the 4 impact on the surgeon and anesthesiologist. The first, we can use the schematics to enhance the cost effectiveness. Yeah, because the patient will have the shorter the hospital stay and reduce the complication rate and lead all to the cost saving and for the hospital or for the everyone. And we can move this resource allocate to who need to this resource. And the second, the patient will have the good response. Yeah, because the patient will get well earlier from the PACU and in the ward. So the patient will reflect the positively to the surgeon and the anesthesia team. And the other will enhance the patient outcome because the patient that will have the less complication and they'll get strength from the anesthesiology. So I think that is good for the take care, the responsibility, and the patient will get their ability to the normal situation. And the last, it will improve the workflow. Yeah, because the sugammatis will short the intubation time and short the stay in the PACU, and that will increase the turnover rate in the OR and in the PACU. So if we have used the concept or the consensus between the surgeon and anesthesiologist, so we can explore our practice, the territory. So that is sentence is also our society the slogan. The more we do, the more we can do. So the WHO they do something, yeah, because they were concerned about safety surgery, because the safety surgery will lead to the saved life. In the beginning, WHO they regulate the surgical safety checklist, like the sign in, time out, and the sign out. That will reduce the human error. And then the WHO issue the global guidelines for SSI for the infection. So many hospital will practice the SS bundle. This bundle will reduce the single or preventable the adverse event like the SSI. So advance, the WHO want to save more life because they want to reducing the surgical complication in the days. So that will use the evidence, the interventions like ERAS that will really to reduce the total complication. So that is the power study. They're very famous. They try to record the CRS patient and try to analyze their ERAS the compliance rate as we look, because the patient will have higher the compliance rate and the patient will have the less the complication and the less the mortality. So safety surgery, by reducing the total complication, I think the ERAS can do it. The classical ERAS the protocol like this, yeah, because we have to separate to 4 stage, and every stage will have several intervention based on evidence and try to treat the patient like before the patient admission, and we'll prepare the patient like we share the decision making with the patient, and we do the pre-operative the optimization, and we encourage the patient receive the prehabilitation, and encourage the patient the smoking and alcohol consumption will stop, and enhance the patient nutrition before the surgery. So that's all we can convince and try to improve the patient situation before the surgery. And the pre-op status we will do the SS bundle and minimal the MPO and give the patient the carbohydrate drink and give the patient the preemptive analgesia and do the different thrombosis, the prophylaxis, such like that. For the anesthesiologist, maybe skillful for the intraoperative, like we use the opioid sparing, the MMA, and we use the standard anesthetic protocol like Squamous will use that in that. And we can do many intervention about PONV the prophylaxis and keep the patient within the normal body temperature and keep the free status in the euvolemia status. As that's all, anesthesiologist can do many things to protect the patient and guarantee the patient safety and will enhance the patient recovery after surgery. So after the operation, the anesthesiologist also can do the better the pain control because we have the good pain control. The patient will get out of the bed earlier, and the anesthesiologist do many PONV the prophylaxis will to encourage the patient the early intake. So that's all is our the ERAS protocol. But we can see the ERAS protocol not just one intervention because they have many intervention because we want to the margin gain to work. Yeah, because maybe the one intervention the improve the small improvement, but and we can guarantee we have two big power to improve of the surgery. So that is to the study. Yeah, the left side is from the Canada and broader to analyze the ERAS the compliance from the low to high above the 70%. And we can see the inverse relationship that because the patient will get the less the complication and the shorten the length of stays. So if we do more the ERAS intervention and the patient will get better outcome. And the other studies from Sweden, the database, they try to analyze the long-term the benefit from the ERAS. And also they correct the CIS the patient and the two group. The one is below the compliance, the 70%, and the other is above the 70%. And we can see the above the 70% the compliance we get better the 5 years survival rate. So what is the ERAS? I think it will include the 5 dimensions. The first is the bundle care and the high quality the bundle care. The second is the patient-centered care, and the third is optimal the medical the resource, and the last is the very best healthcare with EBM. The most important is improve the patient safety with the real teamwork. So we can see the ERAS the bundle care we give the many benefit, including the short term and the intermediate and the long term. Because our care is a continuance, and every patient from the pre-admission, pre-OP, intra-OP, and the post-OP, all keep the same quality of care. So that is a good quality from beginning and to the end. The patient will receive the stable the quality care. And the second, we always say the patient-centered care is very important, but in our hospital or many hospitals in Taiwan, not really can do it. Yeah, because the patient don't know if they have a problem, they don't know to ask someone. Because you ask your nursing in charge, the nursing say, "Oh, that is not my business. You can ask your business staff." And you ask the physician, as a physician say, "Oh, that is my business. You can ask the anesthesiologist." So the patient don't know the question will ask someone exactly. So in the ERAS, we have the ERAS coordinator. She will be the contact window between the ERAS team and the patient. So patient have any problem and ask the coordinator, and the coordinator will give the consensus opinion from the older ERAS team. So that is really the patient-centered care. And the other issue is about the resource. As we know, the ERAS not only to improve our quality of care, and due to they can reduce the complication and shorten the length of stay, and that the economic impact will be in the good way. So we can see the several the surgical protocol will decrease the that's the complication decrease. And the other we want to say is about the very best. Yeah, because ERAS not only decrease the complication or reduce cost only, and we can enhance the the right side is good for patient, and the left side is bad for patient. The vertical line is above is you have to pay the something, and below is you save something. So we can see the ERAS will increase contain this area. Yeah, because like MMA, like Sugama Days, like ERAS team, we just put some investment, and we create the more benefit than to we invest the cost. So that's mean very best healthcare. And for teamwork, in the ERAS team, we always know the when and what, and do some practice in the right patient. So ERAS together, we accelerate the patient recovery. So in Taiwan, we have the department is the Ministry of the Health and the Welfare. Is the MOHW, and the other is the single payer, the institute, National Healthcare Insurance, and the other is our society. So three the units to building the ERAS implementation the structure in the Taiwan. So our society established 5 years, and we just passed our the five years of birthday. So that is really the meeting in the Taiwan. So in our society, we also provide the consensus checklist. Yeah, we write in Mandarin and simplifies the every intervention as the checklist, and we'll provide the healthcare provider worker in Taiwan can for the reference. Like the Sugamedis and the OMT will point from the intraoperative period. And based on that, the government will issue the ERAS as the patient safety goal. That's mean the government buy in the ERAS concept and want to implement ERAS in the Taiwan whole hospital. And we have the 2 round, the patient safety goal, and the second round between the 2024 and the 2025, and ERAS will list the goal 3 safety. We encourage to get a multidisciplinary ERAS team and implement the ERAS protocol in the standard stroke care, reduce the perioperative, the preventable complication, and improve the quality of the patient-centered care. So we also give the ERAS team the compensation from the investment project. That is the primary data. We try to compare the non-ERAS group and the ERAS group, and we can see the complication rate, the decrease, very significant. It decreased 40%, and the length of stay will decrease the 35%, and ICU stay will decrease almost 90%. So ERAS, the group will benefit the reduced complication rate and decrease ICU stay and shorter the length of stay. No difference in the reopen or readmission, and that means we keep the same the quality with the non-ERAS. For the cost analysis, I think the most amazing, because the surgical claim will decrease 25%, and anesthesia crime will decrease 33%, and the total crime will decrease almost 40%, and the total cost, including the out-pocket, will decrease 37%. So ERAS group will benefit reduce the redundancy in the surgical and anesthesia claim from the government, and the other will decrease admission claim from the shortened length of stay and the ICU stay. So total, we can save the 1/3 original cost due to the ERAS. So one should compare the international data to the Taiwan data. We can see the ERAS will decrease the complication rate, and we decrease the intervention rate, and we also readmission rate, and we decrease our length of stay from the CIS, and we create the almost $6,000 per patient for the total care period. So ERAS not only to elevating the care and reduce the cost, and even it can creating the value. So we investigate to the ERAS team about $515 per patient, and we create almost $6,000 per patient. So the return on the investment will be above the 10. So in Taiwan government, they want to balance the healthcare, the quality, and the cost. So we have the patient safety goal, and we also the funding the ERAS team. That this team can do good work and another side to save the valuable resource. So in Taiwan, we do many things to achieve this goal. Like we follow the ERAS society, and we can receive the same consensus, and the government buy-in this concept, so we can explore all the ERAS implementation to all the hospital. And the national patient safety goal will announce we do many work and focus on the patient safety and that will lead to the society to know this ERAS well. And we try to enhance, incorporate the surgeon and anesthesiologist team, and they can do more things and guarantee the patient safety. And the payment system will engage and involve, and they can see the value base, the healthcare to carry up. And that's we implement the quality improvement, the mechanism to the older part, from the POP and to the post-OP, even the patient discharge. So now next, we give the someone in this meeting, if you want to practice ERAS, how to do. I think the ERAS not really difficult. You just find your team. The first, you pick up the one protocol. Yeah, because the ERAS protocol will maybe above the 20 protocol in the ERAS Society, the website. So you can pick one, and you can find the ERAS partner like your surgeon or colleagues, and your nutritionist, the colleagues, and you can find the PT. You can find a good team. And the other, try to establish your consensus. The consensus will base on the EPM, and you can base on the ERAS guideline. So that's we will introduce some good work from MSD from Taiwan. Yeah, because MSD Taiwan give many cooperation opportunity with the society and the government. Like this co-work with the government, and we have the conference, and that is the officer. And the other, they try to do medicine in the patient engage. Like we have many material from the MRT station, and we have explore the many material in the social media, and encourage the patient to understand how to approach the ERAS. And the last, they focus many the publish material to the hospital, like post and many scoring system about the general anesthesia. That will help the anesthesiology to give some risk assessment. So I think that is our society do the ERAS in the Taiwan, and we cooperate with the MSC with Taiwan. So that is hope that this lecture will give us some different concept, and maybe give some good suggestion for the tool. Yeah, thank you your time, and thank you your attention.
So thank you very much, Dr. Guo, for the very informative and inspirational talk. Because we know that in Thailand as well, we do have emphasized on the ERAS program in many modules, in many kinds of the surgery as well. And I would like personally to congratulate your work that you have done to the patients and also into our society. So do you have any question from the floor? I found that there's still no question from virtually platform. While waiting, I have one question for Dr. Guo. You mentioned about the ERAS protocol. Do you actually implemented the neuromuscular blocking monitoring and the reversal protocol into your ERAS protocol as well?
Yes. Like I just introduced the beginning from the scopolamine. Yeah, because we use scopolamine because we base on the ERAS recommendation. ERAS the standard, the anesthesia protocol that will mention about if you prevent the patient from the pulmonary complication, and then we have to measure the muscular block level, and you have to totally reverse the block after anesthesia. So that is the gold standard, and we will ask all the every patient to receive the ERAS protocol. We do that.
Thank you. And that was very impressive. And also you have proven the cost effectiveness of the neuromuscular blocking and also monitoring and also the reversal as well in a very impressive data. Does you have any question from the floor? All right. So I think this is a very informative talk and inspiration. So please give a big hand to Dr. Go again. Thank you.
Yeah, thank you. Good meeting and enjoy your night. Thank you.
All right. So so we come to the last part of the scientific section, and the speaker is me. So I would like to make it quick and short. I just don't want to stand between you and the dinner. So just for me, okay, all right. Oh, I'm graduate from Faculty of Medicine, Sirat Hospital, Mahidol University, and it was a clinical fellowship in liver transplant anesthesia in London, Ontario, Canada. And now I'm an assistant professor at my department. My talk today is gonna be a summary of the reversal options for the better patient's outcome. When we talk about the reversal options of the neuromuscular blockade, for me personally, I consider like three questions: who's you gonna reverse, and when you're gonna reverse, and also which drug would you use to reverse the patients. So about the first question is about the who. So you have to know which patients is at risk, especially the postoperative pulmonary complications. When we think it like easily, that right now the sugammadex has been listed in the Thailand national list of the essential medicines, and they divided into three indications. The first one is the high-risk patients, which is the patient with the neuromuscular disease, like myasthenia gravis, muscular dystrophy, the chronic respiratory disease patients, the chronic renal and hepatic failure, and also the patients with cardiac disease. The second consideration is the operation. It's like the long operation, more than 3 hours, that was indicated to use sugammadex. And the third one is anesthesia perspective, the situation of the cannot intubate and cannot ventilate the patients after you use the rocuronium for that in that situation. So I think about the first question, the who you're gonna reverse. I think easily with this high-risk patients group, is there any supportive evidence that I would like to share? The first one is the systematic review of the case report of the patient with neuromuscular disorders. It was a systematic review of 43 studies or reports, consist of 17 mammography, 15 myasthenia gravis, and 9 other neuromuscular disorders. And they find out outcomes about the successful extubation and also the respiratory complications. And they conclude that in myasthenia gravis, sugammadex provide a fast and reliable recovery with significant reduction in myasthenic crisis and also the hospital cost. However, there's still more to find out about the optimal timing and the dose if you don't want to monitor the neuromuscular blockade level. But actually, in this group of patients, it's a strong recommendation for you to monitor, however. And the quantitative monitoring is still crucial. The second one, the still stronger study, Dr. Guo already mentioned. It was a multi-center match cohort with almost 4,000 pairs with the patient with a high risk of the postoperative pulmonary complication. What are they? It is a patient ASA 3 to 4 the age more than 80 years. The surgery is intrathoracic or intra-abdominal and lasts longer than 2 hours. And they compare the postoperative pulmonary complications. And you can see from the plot of the adjusted odds ratio that it favors the use of sucamadex to reduce the composite pulmonary complications, respiratory failure, and also the pneumonia. What about the patient with actually respiratory dysfunction, which is our one of the indication at the national drug list? This is a single-center retrospective study, consists of 112 patients, and find the rates of the postoperative pulmonary complications. You can see that the most common of the respiratory complications like pneumonia and pleural effusion reduce significantly with the use of sucamadex. What about the cardiac patients undergoing non-cardiac surgery? We have a multi-center RCT consists of 116 patients and a New York Heart Association classification 2 and 3. They divided into 3 groups like sucamadex, 2 and 4 milligrams, and placebo. With this nature of this study, there are some patients that did not have any receive any reversal. They compare the hemodynamic parameters like mean arterial pressure and the heart rate, and also the residual blockade. The positive findings is about the mean arterial pressure and the heart rate was statistically significantly lower in the sucamadex group. In the patient with end-stage kidney disease, this is the meta-analysis of 9 studies with almost 700 patients. The study is about the efficacy in these groups of patients and also the incidence of the residual blockade. You can see that the time to TOF ratio 0.7, 8, and 9 was significantly faster in the sucamadex group in the end-stage kidney patients. However, the report of the recurrent blockade and also the prolonged recovery time is not significantly different between the normal kidney function groups and also the end-stage kidney disease group. The other group of patients that I think is very interesting but is still not in the list yet is the obesity patient that I think is one of the most, for me personally, is one of the most difficult case to manage or to handle about the neuromuscular reversal. This is a meta-analysis of 3 RCTs, compare 165 patients, and to identify the incidence of the postoperative pulmonary complications. And there are favors the use of the sucamadex to reduce the postoperative pulmonary complications in the obesity patient. So I think now we know that the options for who we're going to reverse, there are some, I think there are strong recommendation and evidence that is going to have benefits with a specific reversal agent. So the second and the third question, I think, comes together, like the when and which drug would you use to reverse how about the options. I think Dr. Joy already mentioned is like aggressively about how we can manage the reversal, also the monitoring. So this figure shows that sucamadex is able to reverse at every stage of the neuromuscular blocking levels. So I think it's very handy and very useful, especially when you implement it into the high-risk group patient that I have already mentioned. But the neostigmine is only suggested or recommended to use in the shallow stage of the neuromuscular blockade. And also the same studies that Dr. Joy already mentioned of the European guidelines of the perioperative management of the neuromuscular blockade. I think there are some more interesting statistics. You can see that the first one, with the patient with the shallow stage of the block with the TOF count of 4, with the TOF ratio at 0.1, and you used 50 micrograms per kilograms of neostigmine. After 15 minutes, there's still 1/4 of the patient that still have trend of 4 ratio less than 0.9. So 1/4 of the patients still at risk of the postoperative pulmonary complications, even though they are at the shallow stage of the neuromuscular block. Two more, like at the shallow stage as well, TOF count of 4, and you increase the dose of the neostigmine to 70 micrograms per kilograms. After 20 minutes, there's still 1/4 of the patients that have TOF ratio less than 0.9. And 10 minutes is like 70% that the patients have TOF ratio at the risk of the pulmonary postoperative pulmonary complications. So I think with this evidence that I've shown you, compare, for me personally, I am the one who against they use routinely reverse the patient with the sucamadex according to our socioeconomic. Although we have the like many studies of the cost effectiveness, but we have to realize, especially the patient at the high risk of the postoperative pulmonary complications, just think it twice. Let's see, frankly, the drug cost. The cost that I showed here is the cost at my hospital. It's one of the biggest public hospital. But in the setting of the private hospital, I think it's going to be like many times more than this. But you have to think about it and compare about the cost effectiveness by your setting though. In my hospital, sucamadex costs around almost $100. But when you compare with the conventional neostigmine dose added with the anticholinergic that you have to use, you can see that it's way more expensive, right? But there are some also hidden costs. If the postoperative pulmonary complications occurred and the patient have to go to the ICU, one night of the ICU stays, do you think that they have some other major hidden cost? The ICU bed overnight, the endotracheal intubation, monitoring, suction, mouth care, infusion pump, warmer, other monitoring, arterial lines, even 12-lead ECGs. And this is the cost of the public hospital though. Imagine in the private setting, it's going to be like maybe 10 times more when compared to the one vials of the drugs, neostigmine. And also the hidden cost that we didn't, nobody has already analyzed is the patient satisfaction and also their relatives. If they have their patients, their relatives going back to the ward, can speak freely without any postoperative pulmonary complications. That also the hidden cost that I think you have to be aware. All right, for the hard evidence that I have to show, that's all. But right now I would like to show some interesting case that was in my hospital that has the complications, just to remind you, and I would like some comments as well. I know that in some cases, only the pulmonary complications or the reintubation is not all of the answer. It's not the only predictors or the indicators of how well you take care of the patient. In some patients, you need to remain intubated them, but in some patients, you can prevent it. All right. We called it Club Friday cases in my hospital, aka the morbidity mortality cases. But we just want to be like less stigmatized. The first one, let's follow it together. The Thai female patient, 57-year-old, with parastomal hernia. She was scheduled for exploratory laparotomy under general anesthesia. She has underlying locally advanced of sigmoid cancer, which already do the loop transverse colostomy, and she have obstructive uropathy with bilateral PCN. Like her GFR is around 60. Other initial lab is quite unremarkable. the case was start at around noon with propofol, fentanyl, lidocaine, and rocuronium, 50 milligrams for the rapid sequence induction because she has the attending staff just be careful about the full stomach, and she was maintained with air, oxygen, and desferrin. Her vital signs stable, no monitoring routinely in my hospital, and like going on with the surgery with rocuronium 10 milligrams every 30 minutes, like Dr. Joy said. Maybe their training, maybe the surgeon wants full relaxation of the abdominal wall, I don't know, but they fill it with deep block level though. And then you can imagine the picture. She was finally reversed with neosigmin 2.5 and glycopyrrolate 0.4, extubation, progressive desaturation, reintubation occurs, and transfer to the ICU. I don't know. I want you to like think it with me. What if they're aware of the rocuronium pharmacology, the patient has reduced the kidney function, and we know that some of the rocuronium elimination was throughout the kidney, right? If we have the quantitative neuromuscular monitoring, we can save lots of rocuronium dose, like Dr. Joy said. And also, if we have like spare sugammadex as a backup plan at the end of the surgery, if we use a neuromuscular block, so the patients maybe come out in different way. The next case, the male patients now, 77-year-old with acute femoral popliteal arterial occlusion. He was scheduled for a transfemoral thrombectomy as an emergency cases under general anesthesia. Because the surgeon told us that it's going to be difficult cases, prolonged operative time, and they want the patient to be absolutely still, no movement at all. He had underlying disease like the stable coronary artery disease, chronic atrial fibrillation, and chronic kidney disease as a package of the vascular patients. His initial labs may be like some anemia and the abnormal renal function, as I told you before, but otherwise, pretty unremarkable. They start at the inofficial time, like I said, is at emergency cases. His weight is 65. He was induced with propofol, fentanyl, lidocaine, rocuronium, and was maintained pretty much with the air, oxygen, and desferrin. Pretty stable vital signs, no monitoring, and they go on with the surgery. But they maintain with cisatracurium. I can see this practice like once in a while. With I have to admit that some of our staff or our trainee doesn't keen to use rocuronium after rapid sequence induction and maintain with rocuronium. They do rapid sequence induction with rocuronium and maintain with some other kinds of the drugs, which I don't actually know why, but it happens. Okay. And cisatracurium, because the surgeon just always look up and say the patient maybe moving the legs or something like that, and cisatracurium. And the picture, deja vu, occur and in the same way. Neosigmin, glycopyrrolate, extubation, progressive dyspnea, desaturation, and reintubation. But right now, they do one thing differently. They put the top scan there and find the first value was 0.25. So they give some more neosigmin, the second dose, because it's not exceeds 70 micrograms of the total dose of neosigmin. The patient still like reluctant to breathe. The trainer 4 increased to 0.6. So right now they use sugammadex, 150 milligrams, and the patient returned to spontaneous ventilation, but they're still reluctant to extubate at that time. So they moved the patients to the ICU for overnight, and that's it. That's the story. So when we discussed in our Club Friday conference, if we consider to use continuous use of rocuronium and reverse it at at the end of the surgery with sucamadex after the quantitative neuromuscular blocking drugs, the picture may be different, and the outcome of the patient also different as well. So this is the two cases that I would like to share tonight as my talk. However, I'm the one who uses sucamadex a lot, but not in every cases, as I said. But however, it's not a magic drug. I would like to emphasize on this. There are still some other specific concerns. Recurrentization and residual paralysis is still occur. There are still many upcoming reports, but most of the analysis that they suggest that maybe it's because of the inappropriate doses of sucamadex according to the depth of relaxation. So, not use sucamadex and hope that everything is going to be fine. Neuromuscular monitoring quantitatively is still important. And neuromuscular blocking drug after sucamadex administration, right? You already reverse with sucamadex, but the patient still need maybe get back to surgery. There's some bleeding after tonsillectomy, or there's some bleeding after like thyroidectomy, and you have to paralyze them again for the surgeon just to re-explore. So the elimination half-life of sucamadex in the literature is around like 100 minutes. So some of the advice or recommendation is you can use rocuronium or the other aminosteroid group again after rocuronium like 3 hours. Or you can use other group of the neuromuscular blocking agents, either the benzyl isoquinoline or even succinylcholine. There are some reports about the anticoagulation effect of rocuronium. You can find the transient increase of the PT and APTT. However, there are still no clinical reports of the significant clinically bleeding effects of the patient receiving sucamadex. Hypersensitivity or anaphylaxis you still have some reports, both from sucamadex alone or the rocuronium sucamadex complex. However, it's way less than the other report of the anaphylaxis perioperatively. So right now, we still consider it's pretty safe to use. All right, so my take-home message today, I have two take-home message. This one I bring out from the letter to the editor from the Dr. Brew and Kaufman published in Anesthesiology last year after the the ASA guidelines of the perioperative neuromuscular monitoring and antagonism come out. And that's pretty close to my heart. I believe that also that I would like to share with you is that we understand that some clinicians who have practiced the whole life, like many decades of them, without any monitoring of the neuromuscular blocking, may think that that guidelines was nothing, was useless. But however, the guideline represent evidence-based, right? The prejudice for 20 years or more. And let's just try to imagine that where the medicine goes if we don't believe in the evidence. We may be still like using curare maybe during nowadays. But take-home message for me is like this. Some of you practice like many decades, maybe before I was born or many before I was finished the training. You can you use this road, get to work or get back home every day, no problems at all. But in some days, with the traffic is like this, like today in Nana, so I add that in some other things. So I don't think it's a bad idea to know where to get the expressway, just to make you and your patients get back home or get back to their relatives easily at a peaceful of mind. So just maybe think about it. The cost is not everything, and also the sucamadex or the magic drug is not existed also. All right, thank you very much for your attention. So I think right now we come to an end of our scientific section today. I and in the name of the MSD Thailand, would like to express our gratitude to our attendees for their valuable participation in this meeting. However, I'm sorry, is there any question? Okay, Dr. Surapong, please.
Especially, I like the Club Friday case, and let me share Club Saturday case. Because there's something happening in the northern of Thailand that's difficult to explain, because there we changed the practice a lot for the laparoscopic surgery, and our surgeon like to use a lot of muscle relaxations, and we adapt ourselves. They adapt ourselves, not my case, until we give a lot of muscle relaxations, and at the end of the surgery, this especially in the private hospital, and at the night times after midnight, and they reverse with sugammadex. It's available for a long time. But just lastly, they use a lot more and more muscle relaxation during the operation, because surgeon keep saying that relax a little bit, relax a little, until it's already relaxed like that too much, without the monitor, because neuromuscular monitor, the joint stays very important. In that case, after reverse with the sugammadex, and then everything is okay, and then he go back home, anesthesia back home. 1 hour after that, it look like muscle relaxation come back again. And they think that how about the connection between the rocuronium and the sugammadex? Is it possible to be released, even though already good for a long time, so 1 hour after that, and it will come back again? And the solution of them is use some neostigmine again. They try to reverse with the more sugammadex, and this doesn't work well. So they reverse with the neostigmine again. So it's like, because actually they have to monitor, right? But until now, some hospital, they have the routine that first dose with sugammadex and add on with some neostigmine. Please explain this.
That's very interesting. Firstly, I'm not sure, maybe Dr. Joy can add up or some comments. For me personally, in a long time that I've been used rocuronium, and I think it's also the magic medications. When you use it properly with the proper time and proper dose, I think it hardly has the recuralization or any residual neuromuscular block. Up until recently, many case report and also many analysis that coming out that the recuralization or residual neuromuscular blockade can occur from two reasons. The first one is the dose. Like I said before, the appropriate dose of the neuromuscular of the reversal, according to the monitoring, according to the TOF ratio. If you monitor it, you can analyze and also give the proper dose, and residual neuromuscular block can hardly occur. The second thing is they mentioned about other environment, the body environment that propose or support the muscle relaxation, like hypercarbia or magnesium in pre-eclamptic patients, the patient with hypokalemia that can cause the muscle weakness, can potentiate maybe maybe minimal amount residual rocuronium that may be together with the improper dose of the sugammadex, something like that. That can be the explanation of the recuralization with the patients who are using rocuronium. But I'm not sure whether it can be the reason for this case or not. But from my review, it says that it can occur. Dr. Joy, maybe you have something to add?
Yeah, so just to comment, actually my husband is a surgeon. So the rare times that we work together, and he always tells me, you know what, the he notices that anesthesiologists are very reluctant to add muscle relaxation because you want to finish and you want to get out of the operating room the same time that the surgeon leaves, right? So you don't want to paralyze because you're going to get out later. But then he tells me, you don't want to add, but it's not relaxed, so we work longer. It's harder for them. So if you think that you're trying to make it faster, you're not actually making it the surgery faster. That's one. Secondly, dosing. So you need to be aware of what is the proper dose, not just based on monitoring. Remember, rocuronium is based on ideal body weight, but Sugamadex is based on actual body weight. All right? So what we've noticed from experience and interactions with lecturing, symposia and conferences, because of the cost of the Sugamadex, sadly, a lot of practitioners try to do the shortcut. So even if it's advocated to give, let's say, 2 milligrams per kilogram or 4 milligrams per kilogram based on the depth of blockade, they try to give just, oh, those studies are European or American. Asian patients are smaller. I will just use 1 milligram per kilogram. I will just use 2 milligrams per kilogram. So that may be one problem. So if it's not, you're not guided by monitoring and you're not giving the correct dose, then it's actually not recurarization. It's actually inadequate dosing and improper administration of the drug. And for laparoscopic surgeries, really, there are a lot of studies that you will see advocating depth of blockade, although, which is why in the guidelines it is said by both the American and the European societies that you need to determine if you have to add based on surgical conditions. So you do not actually need to base it on relaxation all the time. It's also based on if the surgeon needs immobility, because immobility is different from relaxation in terms of the surgeon's need. Like maybe for laparoscopy, both are needed, both immobility and relaxation, because if the patient moves, then the trocars can puncture the bowels. So those are, and the studies that I mentioned, actually, their findings were with the proper depth of blockade, then the pressures, the carbon dioxide and the pressures that the surgeons need to operate are lower. So they can operate at 8, 10, or 12 millimeters, even just 8 or 10 millimeters mercury. If it's not relaxed, they have to increase the pressures to 12 or 15. And at the end, that causes more pain for the patient because it stretches the peritoneum. There's deferred pain on the shoulder. You give more pain relievers in the recovery room. So many factors that make so it from my point of view, it might not be recurarization. So about the comment about neostigmine after Sugamadex or even vice versa, they have different modes of action. It's a different pharmacologic action. We have yet to come across studies that do neostigmine after Sugamadex, but there are a lot that give Sugamadex after neostigmine. Again, if you give it based on monitoring, then there is basis for that. I've gotten a lot of questions, like, I've already given neostigmine, like your two cases, where your last case was an example. Given neostigmine, was not reversed, and then responded with Sugamadex. That's a more common occurrence. But again, they have different modes of action, so you may give them, but even if you use both, if you do not monitor, it's not based on monitoring, it's the wrong dose, you're not going to be able to get a conclusion.
Thank you very much. Oh,ครับ
in this situation, they thought that there are some connection between. They have two thoughts. The reversal is not adequate, and they think that if not adequate, is it possible to do neosigmin for the inadequate one to help? Another question is the connection between rocuronium and succinylcholine. Is it possible to release the connection later?
That's interesting. Does the audience, does anyone would like to share? But from the literature, though, that I don't come across any release of the rocuronium succinylcholine complex.
So so I agree with all of you that it's very adequate reversal. I think that ones, but that is the questions come up in many hospitals in northern Thailand. They think like this, just to let you know. But actually, I try to reply that maybe inadequate like this. Thank you.
Thank you very much. All right. So I think I would like to conclude our scientific meetings. It is my sincere hope that the knowledge and the experience we share today will prove valuable in improving the quality of anesthesia and the patient safety for each and every one of you. So I would like to remind that in case of anyone missing any part of our symposium, the replay will be available for the next 7 days, starting off tomorrow. And it will be our deep gratitude for you to write down the evaluation form. That would be very grateful. And thank you very much and enjoy your evening.